Hello, and welcome to this ProCE podcast. I'm your host, Robin Black. Today's episode features a discussion on obesity management strategies that pharmacists can implement in practice. This episode is part of a larger educational program titled Best Practices for Pharmacists to Optimize Use of Obesity Treatment Options and Overcome Barriers to Care. During this podcast, Dr. Megan Adelman from the Cleveland Clinic, Akron General in Akron, Ohio, and Dr. Elizabeth Pogge from Midwestern University in Glendale, Arizona, will provide an overview of obesity and discuss guideline recommendations for treatment, pharmacotherapy options including injectable agents, and overcoming barriers to care. For more information on Dr. Adelman and Dr. Pogge, along with CE-certified microlearning modules with downloadable slide sets, a clinical thought commentary, and a downloadable pocket card quick reference guide, please visit the show notes for this episode. Now let's get started and hear what Dr. Pogge has to say about obesity treatment guidelines and pharmacotherapy options.
I'm excited to be here today to discuss with you some of the barriers to treating obesity, as well as to provide a bit of an obesity overview and an overview of the pharmacotherapy options for treating obesity. Let's get started with Module 1. Our learning objective today is to recognize the pathophysiology and common comorbidities associated with obesity and the benefits of long-term weight loss. I'd like to start with a little bit of background. As most of you attending this CE know, obesity is a significant problem in the United States, and the rates of obesity just continue to rise. In 2017-2018, there was approximately 70% of United States adults over the age of 20 that were considered overweight or obese with a BMI of greater than 25. Of those patients, about 42% met the criteria for obesity, which is a BMI of greater than 30. Childhood obesity is also on the rise, and so this is a significant public health problem. Healthy People 2020 have a goal of promoting health and reducing chronic disease risk through a consumption of healthy diet and achievement and maintenance of healthy body weight. Ultimately, what we'd like to see is the obesity trend start to reverse and less American adults become overweight or obese. Obesity is considered a chronic disease state, and the annual cost of overweight and obesity is approximately 21% of our annual medical spending. And so if we can do a better job of managing obesity, we could potentially reduce our healthcare costs. Let's talk about some of the different factors that lead to this current obesity epidemic in the United States. Economic factors include our food supply chain. Our food is low in cost and abundant. We have significant palatable foods that are easy access and high calorie density and readily available in pre-packaged and fast food restaurants. I live in Phoenix, Arizona, and when I drive down the street, I can't drive more than a few blocks without seeing a fast food restaurant. And there's lines of cars waiting to get these fast foods. This fast, busy environment and fast pace that we're all living in has contributed a lot to how much food we're consuming that is calorie dense and perhaps not as nutrient. There's also a lot of social factors that are really coming into light in the last 5 years. Social factors include things like surroundings. So individuals that, when we think about our children that are in school and they don't have as healthy of lunches, or perhaps they don't live in a safe neighborhood, and then therefore they don't have the ability to go outside and exercise. I think about when I was a kid and I used to climb trees and run around, and then I'd run home when my mom and dad, when the supper bell went off at 6 o'clock. And, my kids, I don't want to let them go a few feet away from my house without me watching them just because of, the environment that I live in. There's tons of cars driving by. People could, in this busy city that I'm in. And this can be very difficult if you live in busy metropolitan areas where there's not sidewalks, where you don't feel safe to go outside and walk. There's also a big concern in this social aspect of food deserts. These are areas where the availability of healthy foods is really limited. So let me give you an example. So you may live in a rural area where the closest place for you to get food is a Dollar General. And that's a mile or two away, and then you have to drive 15 or 60 miles to get to the nearest grocery store. These are considered food deserts. They can also be seen in big cities, where in New York City, perhaps there's a fast food restaurant as well as a corner store that primarily sells sugar sweetened beverages and cigarettes, and you have to walk 2 to 3 miles to get to the nearest grocery store. These are considered food deserts, and individuals that live in these food deserts have a much higher risk of developing obesity. And then our good old technology. We gotta love it, but sometimes we gotta hate it, right? I'm standing in front of my computer screen right now. Most of us no longer have an active job. We spend a lot of time looking at a screen, either as a healthcare professional or, in a pharmacy. There's more electronic devices, there's less physical demanding jobs, and then less physical activity for our children. And most of us are leading a pretty sedentary lifestyle, where if you look at the average number of hours that people sit, self-reported, it's really increased in the last 20 years because we are in front of our technology a lot more. This leads to a conversation about genetics versus environment. Even in obesogenic environment, so that's our current environment with the technology and the food and the lack of physical activity that I just discussed on the last slide, not everybody becomes obese. So why is that? And some people think that it could be related to some of the different genetic variants amongst individuals. There are lots of different genetic variants that have been looked at, and I've listed some of the most common ones, like leptin, which increases satiety, or ghrelin, which increases appetite, or GLP-1s, which also increase satiety. These different genetic variants could contribute a little bit to why one individual becomes obese in the same environment that another individual is in, and that other individual doesn't become obese. Another thing that I have in green on the bottom right-hand side is gut flora, and I have a question mark behind this. This is actually an area that I'm extremely interested in because I think that this is an extremely interesting area of research. The theory is that if we eat healthy foods like fruits and vegetables, fermented foods, whole grains, that our gut flora actually is healthier, and therefore it is able to metabolize things effectively, appropriately, and that individual is less likely to become obese. Whereas if all we eat is processed food and prepackaged food, our gut flora is not healthy and it can't process things as well. And therefore, those individuals will get more obese. And so this is the idea that it's not really calories in, calories out as much as what you're putting in your body. We've all heard the phrase, you are what you eat. And so, putting in nutrient-dense foods can help prevent obesity in our average American, even if they're in this environment of technology, food, and lack of physical activity. When we think about obesity-related complications, this is not an all-inclusive slide, but I wanted to make sure that I listed some of the most common obesity-related complications that you should consider. So when you're working with a male or a female with infertility, obesity could play a role. We know cardiovascular disease, such as high blood pressure and high cholesterol, as well as type 2 diabetes, asthma, fatty liver disease, acid reflux and sleep apnea, osteoarthritis, and depression can all be obesity-related complications. When working with individuals in a family medicine clinic, managing some of these chronic disease states, we always want to think about the underlying risk factor of obesity, assess for that, and consider whether or not treatment would be appropriate. Social determinants of obesity is a very important thing to consider when we're looking at overall our public's health. Social determinants of health is defined as the condition in the environment where people are born, live, learn, work, play, worship, and age that affects a wide range of health, function, and quality of life outcomes as well as risks. There's 5 buckets really within this social determinants of obesity. The first one is that economic stability. The second one is the education. Not just education access, but also the quality of the education. We see a similar thing with healthcare, where it's healthcare access as well as the quality of the healthcare provided. We spoke a little bit on the effect of neighborhoods as well as other built environments, and then social and community context can also be important. Social determinants of health really shape our daily lives and our available choices around healthy food, physical activity, education, job, and financial security, which in turn systemically affects our obesity rates. They're tied really closely to equity issues, such as structural racism, poverty, and community contact. For example, I found a 2019 study that looked at racial inequalities in income, employment, and home ownership and found that they were associated with obesity. When we screen patients for obesity, we can use some of the well-known screening tools such as body mass index and waist circumference. When looking at our body mass index, this is a measurement of our weight in association with our height. And this is probably one of most well-known screening tools for obesity. Overweight individuals are defined as those that have a BMI of greater than 25, where obesity is the BMI of 30 at a cut point, and extreme obesity is a BMI of greater than 40. There is some controversy on whether or not BMI is the best screening tool for obesity, even though it's very widely used and it's very easy to utilize. There are some other things we could consider, such as waist circumference. In individuals that have greater waist circumference, like greater than 40 in men or 35 inches in women, these are considered more of your apple-shaped patients, and then therefore they could have more obesity-related complications. There's also several different scales like Tanita that can provide people body fat percentages that can be useful. So that leads me to really discussing what our management goals are for our patients. So if patients have a BMI of greater than 25, we should provide obesity-related counseling and make sure that they know that a 3 to 5% weight loss can result in meaningful reductions in triglycerides, blood glucose, A1C, and risk of developing type 2 diabetes. So an initial weight loss goal might be 5 to 10% of the current body weight over 6 months. After 6 months, a lot of individuals will gain that weight back. So perhaps focusing on weight maintenance for 3 to 6 months after the initial 6 months can be helpful for a patient. And then weight loss programs can help improve long-term weight maintenance. To summarize this section, we have some practical points. Offer obesity-related counseling to those with a BMI of greater than 25. And obesity is multifactorial, so don't forget the environmental as well as genetic factors that can come into play. Make sure patients know that they don't need to lose 50 pounds in order to cause some meaningful reduction in their obesity-related complications, and offer weight loss programs if it's something that you have the ability to do, because that can help improve long-term weight maintenance. That leads us into Module 2, where we'll talk about our treatment guidelines as well as pharmacotherapy options. For this module, we will summarize the treatment guidelines as well as talk about lifestyle modifications and evidence-based pharmacotherapy options for the management of obesity. The guidelines I'm going to focus on for this presentation are the 2016 American Association of Clinical Endocrinology and the American College of Endocrinology. These guidelines are comprehensive, where they discuss lifestyle intervention as well as pharmacotherapy. In terms of lifestyle intervention, there's 3 main components that should be considered: dietary, physical activity, and behavioral therapy. We're going to discuss some practical tools that you can utilize as we move forward within each of these realms. We want to make sure that we're considering pharmacotherapy added to that lifestyle intervention in all patients who qualify. When we start with our dietary therapy, we also need to be reminded about calories. So approximately 3,500 calories should induce a 1 pound weight gain in a week. So you want to encourage individuals to find a plan where they can cut approximately 500 kilocalories per day in order to lose 1 pound per week. And we'll discuss some of the most known meal types or meal plan options as we move forward in the presentation. But it is important to think about a patient's life, style, and individualize that dietary therapy. So if you take a patient that primarily eats meat and you say, go be a vegetarian, that's probably not going to help them. So we need to think about where they're at, meet them where they're at, and provide small changes that can make meaningful difference. In 2022, the USDA updated their dietary guidelines, and the current 2020 to 2025 US dietary guidelines are available to download offline. They have emphasized the continuation of the My Plate method, which I think is very easy for patients to digest, where half of the plate is fruits and vegetables, and the other half of the plate is grains and protein. And they've really had a renewed emphasis on focusing on whole fruits and whole vegetables, as well as varying your fruits and vegetables. And then a renewed emphasis on making half of your grains whole and varying your protein content. So protein doesn't have to come from meat. Think about legumes, beans, fish, nuts, and seeds. And then the continuation of low-fat dairy or fat-free dairy milk or yogurt or lactose-free dairy alternatives, such as soy versions, have been recommended. And then they limit foods and beverages with added sugar, saturated fat, and sodium. So this leads back to this idea of what you're putting in your body and making sure that you're putting healthy foods in your body, healthy fruits and vegetables, healthy grains, and healthy proteins. When we think about our built environment, we need to think about how individuals can access these things. And so one of the tools that I utilize is discussing with patients if they can't get fresh fruits and vegetables or they go bad, what about frozen that has no added sugar? And so making sure you're working with patients and meeting them where they're at to try to help them based on their built environment. Some of the most common hidden diet derailers that I see in clinical practice include alcohol, as well as sugar-sweetened beverages, condiments, snack foods, and skipping meals. In terms of alcohol, it's important to know that this is a very high calorie per gram food or beverage, I guess, and also can increase an individual's appetite, and then therefore they can eat more when they're consuming alcohol. So if individuals are willing and they're trying to reduce their weight, that one of the first things I try to cut out is alcohol. There is no significant nutritional value to alcohol, and so those are generally empty calories. While it can be very controversial on whether or not this, overall can provide some heart health. Sugar-sweetened beverages are another one of those things that we consume a lot of in the United States and really needs to be reduced. This is things like sodas, but also things like sweetened teas, juices, as well as milkshakes, as in our picture, and then drinks from places like Starbucks or coffee shops. Some of these can have up to 500 to 600 calories per drink, and so that can really be a diet derailer. Condiments. Salad dressings, people oftentimes think about, but let's think about other condiments. Ketchup is really not that great for you. There's a lot of added sugar in ketchup, and oftentimes people that use ketchup are using a lot of it. Barbecue sauce has a lot of added sugar. Sometimes that can have up to 60 calories per 2 tablespoons. And so think about the condiments people are using and try to find alternatives that may be healthier. So maybe they could use vinegar and oil instead on their salad in place of ranch. Sometimes when you look up different salads online at fast food restaurants, you'll find that they're actually worse because of the condiments that they're putting on them, such as cheeses, croutons, and then significant amounts of salad dressing. We think about our snack foods and junk foods and candies as being bad, but we oftentimes underestimate how much we're eating. So these are products where maybe we're sitting in front of the television and we're just stuffing them in our mouth. And so we're not having or practicing mindful eating. And so we may eat a bag of chips before we know it. Or perhaps we're at work and we walk by somebody's office and there's a candy bowl and, we just grab one here or there and we grab 2 little pieces of candy every day. Well, that's 100 calories. And those are not things that we're thinking about. And then counterintuitively, for some people, skipping meals can be a significant dietary derailer because they can be so famished and so hungry at the end of the day that they actually overeat once they get to their meal. So unless if a patient's practicing an intermittent fasting type diet, I generally suggest against skipping meals for overall health. There is no good research to show how many meals a patient should have per day. So it really is based on what works for that patient. So if they like 6 small meals a day, if they like 3 meals a day, it's really more important about what they're putting in their body. Some of my patient counseling tips are very consistent with what I talked about with our dietary derailers. I start out with suggesting that people don't drink their calories, except if they're drinking milk. That's an okay calorie for them to be able to drink. Now, things like coffee, black doesn't have calories. So, that type of thing is okay, or unsweetened teas. Tracking food intake can be an extremely powerful tool if it's done right. MyFitnessPal or other apps can be utilized in order to track food intake. And this can be really helpful for patients in terms of A, awareness, and B, it can be a nice behavioral change tool. Because perhaps if you need to track your food intake, you're not going to eat that entire bag of chips, especially if you're honest with yourself while you're tracking. Whenever I suggest tracking food intake, I know that it's a tedious process. So I suggest that individuals do it for approximately 3 days, and that they do it while they're eating foods, instead of going back and saying, what did I all eat today? Because that's very difficult to remember for most people on what they all put in their mouth. And then you also need to make sure that they're tracking their drinks as well as tracking their condiments, some of those hidden diet derailers. You want to limit the extras to no more than 200 calories per day. So this is my idea of not depriving. So let's say you're working with a patient and they're like, I really love cookies. I'm like, okay, well, maybe what we could do is just have 1 cookie a day, and that's your extra. That's your sweet, your soda, that's your whatever. We need to limit all of our other extras. And so you can have that 200 calories of cheat per day. I think this is helpful because it allows people not feel significantly deprived and not get to the end of the week where they haven't had any sweets or any extras, and all of a sudden they eat an entire sleeve of Girl Scout cookies. Increasing water intake can also be very helpful, especially prior to meals. That potentially can increase satiety. I suggest non-starchy vegetables being the star of the plate. So I tell people you can have as many non-starchy vegetables as you want. And I define non-starchy vegetables for them, making sure that they understand that this does not include potatoes, corn, and peas. And then they can have unlimited non-starchy vegetables, and then adding on additional healthy things. And then limit restaurant meals to once per week. So restaurants can be very difficult to make healthy choices in. Oftentimes they use a lot of butter, a lot of salt to cook with. That's why it tastes so good. And so if you can limit your restaurant meals to once per week, that can kind of make it a treat, allow you to get whatever you want when you go to the restaurant and not derail your diet. In the US News publishes every year the best diets. So I thought it'd be interesting to show you in 2021 what they thought were the best diets. And this is pretty consistent with how I feel like. So if I have a patient come to me and say, I really want a diet, I'm generally telling them that if they want to follow a specific diet, that one of these diets is beneficial. So the Mediterranean diet, which you may be familiar with, is one of the diets that has the most data to show that it can reduce cardiovascular disease. It's rich in fruits, vegetables, grains, beans, nuts, legumes, seeds, fish, and seafood. It's pretty low in poultry and eggs, cheese, yogurt. And then it avoids at the top of the pyramid meats and sweets. The DASH diet is a dietary approach to stop hypertension. And this is similar to the Mediterranean diet, where it's rich in fruits, whole grains, and it allows for about 6 ounces of lean protein a day. It recommends about 5 servings of legumes per week and 3 to 5 servings of low-fat dairy. This diet emphasizes a reduction in sodium and an increase in potassium. The flexitarian diet is really a vegetarian diet in which individuals don't eat meat products, but they are allowed meat products when they feel like it, maybe once a week as more of a flexitarian type lifestyle. The MIND diet you might not be familiar with. This was created to help prevent dementia. And this combines the Mediterranean diet and the DASH diet. It stands for the Mediterranean DASH Intervention for Neurocognitive Delay. It's rich in 10 foods to eat. It includes vegetables, leafy vegetables, berries, nuts, olive oils, whole grains, fish, beans, poultry, and it says 1 glass of red wine a day, and 5 foods to avoid: butter, cheese, red meat, fried food, and pastries and sweets. And then the Mayo Clinic diet is another diet that fell onto the list, and I've included the pyramid here. As you can see, most of these diets are very similar, right? Rich in fruits and vegetables, moderate whole grain carbs, lean protein sources, as well as fish, dairies, nuts, limited added sugar. In terms of physical activity, the Move Your Way is the current public message available for adults when looking at prescribing physical activity. I suggest that they do moderate intensity aerobic activity such as walking at least 150 minutes per week. And then along with this is the suggestion of at least 2 days per week of muscle strength activity. This can be traditional weightlifting, or this could be something like yoga. When you're writing an exercise prescription, you want to start low and go slow, but go and get up to at least that 150 minutes per week. Scheduling activities or making it a group session can help individuals stick with that exercise. I also like to find things people like so they can make it fun. In Arizona here, and pickleball is really popular, bocce ball, bowling among our older adult population. A lot of people like to hike. And so, make it fun for the patient and try to find ways that they can stick with it. And then increasing our daily activity can be helpful too. Taking stairs whenever possible, parking far away in the grocery store and walking in. Some of my older adults, they'll just tell me, I walk around Costco for an hour or two. I'm like, well, that's great. That's great activity. Although you are bunching up the aisles in Costco for those of us that need to shop, right? But those types of things are great. Getting in a store, walking around, just moving can be very helpful for this obesity epidemic. Behavioral therapy is another thing that should be considered. I want to point out that CMS does provide reimbursement for up to 20 sessions per year. I've been involved in several programs where we've offered obesity counseling, and we've formed it over approximately 14 sessions of about 6 months. And most of the time we've done it in group sessions, although I have done individual counseling as well. Pharmacists in most states are not recognized as providers, but we've gotten around this by attaching ourselves to somebody that is considered a provider, such as an MD or a mid-level provider that's in your retail setting, and you can bill through them. I've mentioned food apps already, but also weighing in regularly can be helpful. I suggest individuals weigh themselves not too often, but approximately once a week in order to keep track. Because remember, we're going for slow, steady weight loss, not significant weight loss in 2 to 3 days. Closing the kitchen can also be helpful for individuals that snack a lot at night, with the idea of not eating anything after 6 p.m. or 5 p.m. Keeping food out of sight or out of the household can be helpful for snack foods such as chips. And then practicing mindful eating, which is really this idea of paying attention to what you're putting in your body and enjoying what you're eating when you're eating it. Getting adequate sleep and reducing stress can be helpful, especially if those are triggers for overeating for that individual. And that leads us to that identification of what is triggering them to overeat. Can we identify and avoid those? As a pharmacist, it's important to look at their medications and think about what are some reversible risk factors. So there are some different medications that are well known to cause weight gain and potentially drugs that you could utilize to promote weight loss or that are more weight neutral. Let's just look at examples like our antidepressants. Mirtazapine and our tricyclic antidepressants are well known to cause weight gain, as well as some of our selective serotonin reuptake inhibitors, whereas an antidepressant like bupropion actually can promote weight loss. Looking at our mood stabilizers, I do want to point out that I have lithium in this table twice, and that's because lithium has been associated with weight gain and also being weight neutral or with weight loss in some individuals. Oftentimes, this is related to the fact that maybe a patient was on a mood stabilizer such as valproic acid that caused some significant weight gain. And when they switched to lithium, they actually had weight loss. So perhaps lithium for most patients is more weight neutral. Our anti-diabetic agents that promote insulin secretion, such as sulfonylureas, or insulin itself actually promotes weight gain. Whereas some of our other agents, like our glucagon-like polypeptide 1 agonists, metformin, our SGLT2 inhibitors, actually can promote weight loss. When looking at hormonal contraceptives, some individuals feel like oral contraceptives can promote some weight gain, but they haven't over the long term in clinical trials consistently shown that. It may just be more associated with lifestyle changes, whereas injectable contraceptives that are just progesterone have been associated with some weight gain. So that leads us into our pharmacological treatment options. As I've mentioned, they are indicated in patients with a BMI of greater than 30 or those with a BMI of greater than 27 with concomitant obesity-related risk factors. You should always implement these along with lifestyle changes that I've mentioned before, dietary, physical activity, and behavioral change. You want to assess efficacy monthly for the first 3 months, then every 3 to 6 months if you decide to continue it long term. And an effective response at 3 months is considered greater than or equal to 5% reduction in body weight. If a patient does not have an effective response at 3 months, the recommendation is to discontinue the pharmacotherapy and try a different agent or just do lifestyle alone. Let's look at our options. First of all, I'd like to orient you to some of the key parameters of clinical trials for weight loss medications, as this could help when you're thinking about the patient in front of you and if they're an appropriate candidate for pharmacotherapy. Most of the clinical trials for weight loss medications included a middle-aged female of 40 to 50, and about 70 to 85% were female. The baseline weight was approximately 100 kilograms, which equated to a BMI of about 36 to 38. And the average length of these clinical trials is 1 year. There are clinical trials that looked at continuation of these therapies and did show that patients were able to maintain weight loss. But after 1 year, the weight loss will potentially plateau for most individuals. And the average percentage weight loss of completers is about 5 to 10% of their body weight. And I'll show you what some of the differences between the agents on the next few slides. So this is a list of the current FDA-approved weight loss medications. We'll start with our sympathomimetics at the top of our slide. You may be more familiar with phentermine. That's the agent that I'm most familiar with, but there are other agents in this class. And they are between Schedule 3 to 4 controlled substances because they do have addictive properties, and they should only be used short-term for weight loss, where they can induce about an 8-pound weight loss of approximately 2 to 24 weeks. These work by norepinephrine stimulation or norepinephrine release. Phentermine topiramate, ER, is a combination drug that is recommended for long-term weight maintenance or weight loss along with long-term weight maintenance. And it is still a Scheduled 4 controlled substance because of that phentermine component. This adds a GABA receptor modulator to that phentermine or to the phentermine component to make a combination drug of two commercially available products. Of note, topiramate is one of those mood stabilizers. At approximately 1 year at the high dose, this drug has been shown to induce approximately a 19-pound weight loss. Naltrexone bupropion is a combination of an opioid receptor antagonist with a dopamine and norepinephrine reuptake inhibitor. In this clinical trial, at approximately 1 year, the average weight loss was approximately 10 pounds. I want to point out before I move much further that the weight loss that I'm pointing out here is above diet and exercise alone, mean weight loss. And so all of these drugs were compared to diet and exercise alone. And so this is really that weight loss above diet and exercise alone. The next two agents are our GLP-1 agonists, liraglutide and semaglutide, that are approved for obesity. Liraglutide induced approximately a 13-pound weight loss at 1 year, and semaglutide was studied up to 68 weeks and showed about a 28-pound weight loss. And so that is the drug that has been shown to be the most effective weight loss medication of the current FDA-approved medications. Orlistat is available over the counter and via prescription and induces about a 6 to 7 pound weight loss at 1 year. The nice thing about this drug is it is available over the counter, and it also works a bit on behavioral change because it is a lipase inhibitor, and it causes a 30% reduction in fat calorie absorption. And because of that, when individuals take it, they can have some unwanted side effects, and it can't, when taken with a fatty meal, so it can induce a bit of behavioral change and have them not eating as much fat in their meals. Looking at the different dosing of the FDA-approved weight loss medications, the sympathomimetics are given once daily in the morning. I didn't list all the dosing of all the agents on this slide. I just listed phentermine, but it is important to note that there is different dosings for each agent. All of the other weight loss medications that we have, except for orlistat, should be titrated up. So they start at a starting dose, and then they go to a recommended dose and then a high dose. When we look at phentermine topiramate ER, that's a once daily medication, whereas naltrexone bupropion at the highest dose is twice daily. Liraglutide is given once a day, and semaglutide is given once a week. It's also important to note that the high dose of both of these agents is much higher than the dose utilized to treat type 2 diabetes. And then the difference between the orlistat over-the-counter and prescription is just the dosing. The over-the-counter dose is half of the prescription dose, and this is given 3 times a day with each meal. Orlistat will not work if it's not taken, so it's really important that a patient take it 3 times a day with the bite of each meal in order to induce that reduction in fat absorption. Let's look at some of the side effects as well as other things that we should consider when looking at prescribing these weight loss medications. Our sympathomimetics are Schedule 3-4 controlled substances, and they have a high risk of dependence. They're only indicated for short-term use, approximately 12 weeks. These traditionally have been around for a really long time, and in the 70s and 80s, I had some pharmacists that used to tell me that they were known as the housewife drugs because, housewives would take them because they really liked that they gave them energy and suppressed their appetite and allowed them to get more done. They are also available as generic and relatively inexpensive. Therefore, they don't have to go through the insurance, which makes patient affordability nice with these agents. Although I really want to reiterate that they should only be used for approximately 12 weeks because they can increase blood pressure and increase heart rate. They also cause some insomnia and agitation, and they have been associated with some ischemic events. Phentermine topiramate extended release has been associated with a little bit of increase in heart rate in the clinical trials, but the blood pressure elevation was much more blunted when it was given in this extended release formulation. The topiramate component of this drug is associated with some cognitive impairment. And I think that's important to note when you're educating patients. If they really need to be with it with their job, they have, a high stress, think on your feet type job, this medication might not be right for them. There's also been some increase in serum creatinine and metabolic acidosis seen with this medication. And because of the topiramate component, which is teratogenic, this is a REMS medication that is only available through certified pharmacies, and you want to make sure patients are getting regular pregnancy tests and using adequate birth control. Naltrexone bupropion, because of the naltrexone component, should not be taken with chronic opioid therapy. And the bupropion component causes it to have that black box warning of suicidality with antidepressants. And also, because bupropion is contraindicated in seizure disorders, you would not want to use this agent in a patient that has a history of seizures. This can cause some mood changes, nausea, dry mouth, insomnia, and dizziness. The GLP-1 agonists, liraglutide and semaglutide, are associated with a lot of GI issues, such as nausea, diarrhea, and delayed gastric emptying. They also rarely can cause pancreatitis, and they can cause hypoglycemia, especially when taken in a diabetic patient who is also on insulin or a sulfonylurea. These are given as a subcutaneous injection, and there is some risk of thyroid carcinoma that was seen in rats with these. It is not known how applicable this is to humans. Orlistat has those significant GI effects where it causes you to not absorb fat from your stool so that you can have flatulence with discharge, fecal urgency, or fatty stools. And because this reduces the absorption of fat-soluble vitamins, you want to take it with a multiple vitamin separated by at least 2 hours. And that leads me to my practical points. Make sure you include lifestyle counseling for all patients with obesity, and also think about behavioral therapy. Utilize technologies when appropriate, and consider pharmacotherapy for patients that qualify, and think about our different FDA-approved medications and choose the one that fits your patient best.
Thank you for that great overview, Dr. Pogge. Next, Dr. Adelman is going to speak to us about recent advances in injectable treatment options for obesity and overcoming barriers to care.
Thank you for everybody that's calling in today. I think it's always exciting. We had such a great session from Elizabeth from session 1 and 2, and hopefully we'll highlight some of that content as well as moving forward with some of the others. The session 3 that we'll be first starting on is best practices for pharmacists to optimize use of obesity care options and overcome barriers. So where I'd like to start with is talking about some of our injectable therapy. I'll be referring to glucagon-like peptide or GLP-1, which is expressed in multiple areas of the body. This slide features the multiple activities that GLP-1 agonists have, with those in purple highlighting the weight loss benefits, primarily in the intestines to slow down gastric emptying, the brain to decrease appetite, and the adipose tissue to increase lipolysis. Historically, we've seen GLP-1s used for diabetes management. However, currently we only have liraglutide and semaglutide as options for weight loss therapy in patients without diabetes. As a class, though, we have some general considerations. One of the first things I usually think about is a patient a candidate for a GLP-1 agonist? Some contraindications we think about is I always start the question with, do you or your family have any history of thyroid cancer? Specifically, we're looking for medullary carcinoma as well as MENS2 type cancer. This is primarily based with some of our rodent studies. However, this has been extrapolated to patients as an overall absolute contraindication. Some of my other considerations that I have when prescribing GLP-1 agonists are relative contraindications or considerations. You'll see that I have history of pancreatitis is listed as a consideration with a question mark. This is somewhat interesting and a little bit of a gray area of practice. So if somebody has chronic pancreatitis, something like they're on pancreatic enzymes, I usually say this is a no-go just because that mechanism of action where we're slowing the GI tract. But if somebody has a remote history, they have acute pancreatitis, we can say that we can usually safely use this as long as the causation factor has no longer present. So an example of this, I've got a patient that's on a GLP-1 agonist. About 5 years ago, she had an acute episode of pancreatitis because of alcoholism. She's been completely sober for the last 5 years. We safely can use this. The studies are similarly showing where these patients are included in the studies for GLP-1s. The other relative consideration that we think about is gastroparesis. Again, if we think of our mechanism of action for our GLP-1s that we had on the other slide where we have the slowing of the GI tract, severe gastroparesis is not going to be good with this just because we're further slowing that and causing potential symptoms. If we determine that the patient is a candidate for a GLP-1, we really need to start counseling about some of our side effects. I've included all of them here that are our major ones, with those that are most common bolded, so our nausea, vomiting, dyspepsia, as well as abdominal pain. And this is primarily related, again, to our mechanism of action of slowing the GI tract. Overall, it's interesting. In my practice, I've seen where these are relatively transient in nature. So this usually within the first couple of weeks may or may not happen. If patients can get through those first couple of weeks, we start to see some resolution of those symptoms, but they can occur with each dose increase. And one of the last couple of things to think about, again, this relates back to our side effect, mostly with the bloating nausea. I usually say we can mitigate this through mindful eating. So what I talk about is because that slowing of the GI tract happens within the first couple of weeks, if patients overeat, they will start to see that adverse events a little bit more commonly. So we talk about the plate method quite a bit in our weight management clinic. So looking at the plate, eat half of it. If you're still hungry after that, that's absolutely fine to continue. But a lot of the times patients are surprised by how quickly that onset happens and that they're full within that first half plate and don't need to extend further. This is a great option not only to help with adverse events mitigation, but then also for effective weight loss. We see both the FDA-approved GLP-1s, liraglutide on the left-hand side, as well as semaglutide on the right-hand side. And we include in each graph both the diabetes as well as weight loss dosing. Diabetes on the left-hand column, weight loss on the right-hand column. We can see for weight loss, we not only include the diabetes dosing at lower doses, but then we have 2 higher doses or step-up therapies for weight loss. With liraglutide, we step from 1.8, our maximum diabetes dose, to 2.4, and finally the maximum dose of 3. And then with semaglutide, our max dose for diabetes at 1 up to 1.7 and 2.4. I do want to note that later this year, we may see that 2 milligrams of semaglutide for diabetes coming to market, which would be incredibly helpful for both diabetes as well as weight loss. Similarly, for both, we see a dose titration schedule, liraglutide about every 1 to 2 weeks, semaglutide every 4 weeks, and this is hopefully to help with mitigation of that GI side effect profile. Now let's get into some opportunities to talk about where the pharmacist can play a role. Not only can we help with initiating therapy, but we can also talk about some of our counseling for side effects. Really where I feel like I fit into play is determining some cost considerations. Unfortunately, these tend to be very variable and is very insurance specific. In my area where I work, some larger corporations like FedEx and Lowe's have these as tiered items. But it usually is important. I always encourage when I'm considering these to have the patient call their insurance to determine if this is on formulary and see what the coverage strategy looks like. So for example, I had a patient where I had recommended this. It showed on our end to be on a tiered system, but when she called the insurance, it was on such a high tier that even with the copay card, it was going to be about $500, $600 a month. Interestingly, and we had a question come up about this, about coverage for other medications, but so far I don't see where either of these agents, liraglutide or semaglutide, for the obesity dosing does not appear to be on any of the Medicare plans, and Medicaid tends to be fairly state specific. I've not heard, at least in my area, where any Medicaid plans are covering this. I'd love to hear about it in the chat if anybody's seeing elsewise. There is some discussion in some states about covering these, but currently I'm not seeing where these are available. Of note, it is important that each of these have available manufacturer coupons, so these would be available for individuals with private pay. However, there is the downside that there is a cap coverage per month, meaning that patients may still be left with high copays. Previously, you might have seen in 2021 that semaglutide had a coupon that cut the cost down to about $25 a month, regardless of the cost after insurance. However, this coupon expired at the end of 2021, and I see where cost continues, unfortunately, to be the biggest barrier for these medications. Currently, both out of pocket without any coverage is around $1,300, which is fairly significant. The final consideration that kind of goes in line with cost is also access. For a while, semaglutide, when it was first FDA approved for weight loss, some strengths were not able to be obtained by pharmacies. I've seen where that has had some resolution, but that cost barrier still stays in place. One of the other key counseling points for pharmacists to consider is how to administer the medications. The first slide we have on here is our liraglutide pen, and you'll see multiple similarities between liraglutide for diabetes and liraglutide for weight loss. Both are the multi-use pens that we see on the right-hand side of the screen, and the selection of the doses on the side and a separate order for needles is required for both. To use the pens, patients do need to prime it, so they'll dial up until they see that ... on the first kind of crank, and they should press the button down on the bottom to ensure that liquid comes out before injecting. This is only with the first time use of the pen. Once this is done, the patient can dial their correct dose, so whether that be for our weight loss, our 2.4 or 3 milligrams, they take the pen and inject it into a fatty area, most commonly the stomach, as well as outer area of the thigh is sometimes used at a 90-degree angle. Push the button down until they see a 0. We can actually see the 0 on the pen that's on the right-hand side of the screen. Keep in mind the patient should also use a new needle with every administration. The order for the needle is the most common error that I see in terms of the actual prescribing. Unlike the other GLP-1s, you do need to actually do a separate order for the needles. But again, multiple time use, we keep it in the fridge between each one, but it's good to go. Now compare this to semaglutide for weight loss pen. This more or less resembles more of a duaglutide-like pen where it's a one-time use. You remove the bottom of the cap. So on the right-hand side of the screen, the darker gray area is going to be this cap portion. This opens up almost like a trigger or where the needle is. This portion that is opened goes against the area of the skin. Again, albeit a more fatty area. Most commonly where I see patients do it is in the stomach or outer part of the thighs in the fatty area. They push it down and they'll hear 2 clicks. The 2 clicks is necessary for the injection itself. You can actually see in the viewing window, as I'm highlighting here, as well as on the right-hand side here, there will be a yellow plunger that goes down. Once they see that yellow plunger throughout, they've actually given the dose itself, and then it's continuously fine to take away from the skin. They've done a successful injection. Keep in mind that each pen and dose has its own unique pen. Once that pen is used, we completely throw it away. So the main difference between the liraglutide and semaglutide, liraglutide is a multi-use pen, semaglutide is a one-time use pen. Liraglutide has the needle exposed, whereas the semaglutide does not. So let's get into some of the evidence with utilizing these therapies. One of the first trials that assessed GLP-1 effectiveness was with Astrup and colleagues in 2009. This study looked at 4 different doses of liraglutide versus prescription dose of orlistat for 20 weeks. In addition, patients were encouraged to do a 500 kilocalorie deficit diet and increasing activity. Patients were included in this trial if their BMI was over 30, had stable body weight for about 3 months prior, so not fluctuating more than about 5%, and they were interested in starting medications. Patients were excluded if they had either type 1 or type 2 diabetes, had prior weight loss therapy prescription in the last 3 months, or prior bariatric surgery within the recent years. Overall, for the patients that were randomized to the liraglutide trial, they were up-titrated to their target doses over 4 weeks, and about 560 patients were enrolled. Overall, we can see on the screen there were very positive findings with liraglutide versus orlistat or placebo. Overall, liraglutide took the cake, no pun intended, in terms of positive findings, outperforming, where we can see with on the left-hand side of the screen, with about 76% of patients losing 5% of their weight with liraglutide versus 44% with orlistat. That's about a number needed to treat of 4, so fairly significant. Again, large percentage of individuals that lost 10% of the weight, about 28% with liraglutide versus 9.5% with orlistat, with a number needed to treat about 10, a number needed to treat around 5, And then pretty significant average weight loss. So we're looking at about 20 weeks. our average weight loss was right around 15.8 pounds or 9.2 kilograms with liraglutide. Again, significant, almost double what we saw with orlistat. This slide actually evaluates the actual weight loss per dose. So that prior slide on the right-hand column looked at that average dose over liraglutide, but we see a fairly consistent trend up with more weight loss the higher the dose that we do. It's important to note that we do see weight loss with our diabetes dosing. So our max dose of 1.8, we see of about 7 kilograms. With these higher doses up to our max of around 3 milligrams, we see an additional 2 kilogram loss over that time frame. So fairly significant, and we can see why we have that benefit of increasing the dose. Interestingly, this study also looked at blood pressure changes, and we don't really see any changes in blood pressure with higher dosing. Really, this is most consistently with our weight management. I think unsurprisingly to anybody that has prescribed or monitors GLP-1, we did definitely see higher rates of GI side effects with liraglutide versus orlistat, as well as seeing higher rates of GI side effects with our higher doses of liraglutide. This was most notable with constipation. Between 11 and 17% of patients prescribed liraglutide experiencing constipation. Nausea was also fairly significant, between about 24 and 47% of patients reporting it with liraglutide. Vomiting between 4 and 11, and then generalized fatigue at around 3 to 10. Again, not surprising. If we compare liraglutide to orlistat, orlistat had significantly more diarrhea, which is pretty consistent with our prior literature for orlistat. One of the positive things, though, is that withdrawal rates appeared fairly similar throughout, though we did see higher rates of withdrawals due to side effects with our higher doses of liraglutide, ranging between about 5 and 10%. However, our lower doses were pretty consistent between 3 and 5-ish% with our lower doses of liraglutide, orlistat, and placebo. So this indicates, again, no surprise, higher GI-related side effects with our higher doses of liraglutide, bigger bang for our buck in terms of weight loss, however. Now let's compare this to one of our newer studies, now looking from switching from liraglutide to semaglutide. So Wadling and colleagues replicated a similar study looking primarily at semaglutide, but only versus placebo, incorporating also dietary changes and activity changes. Almost 2,000 patients were enrolled, but this was for a 68-week study with fairly significant findings for semaglutide. Patients were included if they had a BMI over 30 or if above 27, consistent with our guideline recommendations, if they had other conditions such as hypertension, hyperlipidemia, sleep apnea, or cardiovascular disease. Patients were excluded if they had diabetes, chronic pancreatitis, or acute pancreatitis within the last 6 months, or any use of any medications for weight loss within the last 3 months. For our semaglutide dosing, it kept consistent with that prior slide that we talked about, starting at 0.25 weekly and then increasing in a stepwise fashion every 4 weeks to a target of our 2.4 milligram dose. It's interesting, and we'll talk about this as part of the strategy. Dietary changes as well as activities were logged every week in a journal, and we'll talk about why that's significant in a couple of later slides. Interestingly, if we look at this versus our prior slide, this is probably one of our largest studies to date in terms of percentage of patients that lost 5 and 10% of their weight loss. So we see almost 90% of patients on semaglutide, 86% lost about 5% versus 31% of placebo. Similarly, with our 10%, semaglutide really outperformed placebo at around 69%. It is important to note that this was for 68 weeks versus 20 weeks with our prior study. However, what really drew my attention was this 15% weight loss. This is probably the most notable study that we have to date where we have such a high percentage of individuals losing 15% of their weight, with about 50% with the semaglutide losing 50% of weight loss. That's very significant, even though we saw a longer duration of the study compared to others. This looked at about a number needed to treat of 3. So we are seeing actively where active therapy definitely helped and outperformed placebo, where both groups were doing dietary and lifestyle interventions. Overall, patients lost on average of about 33 pounds or 15.3 kilograms with semaglutide use. The other positive that I just find super interesting was with some of the evaluation and change in body weight overall. I really want us to focus on the left-hand side of the screen. It's fairly interesting. So we start to see weight loss within the first 4 weeks of initiation of semaglutide. With a gradual dose, or with our dose increase, we also see almost like a stepwise approach to further weight loss. We do not see a plateau at all. It starts to level off at the end of the study, but this is such a beautiful gradual decline in weight, almost supplementing a really, really nice healthy weight loss. This is positive because, again, patients did not see a plateau and the dose continued to have effects throughout the duration of the study. Similar to our prior trial, GI side effects were the most common, with nausea, diarrhea, vomiting, dyspepsia, and constipation being more active in our semaglutide arm. Interestingly enough, though, we did see some complaints even within the placebo arm, but those were the ones that really stood out. Again, highlighting the fact that GLP-1s we do have to worry and counsel patients on, especially within the first couple of weeks. I do want to spend a brief moment looking at some of our newer data with GLP-1s because, again, we are frequently using these for diabetes management. And ultimately, I'm also trying to use it for anybody that even looks like they have a hyperglycemia picture, potentially even prediabetes, using it off-label. This first trial, the SUSTAIN-7 trial, was published in 2018 and looked specifically at diabetes dosing for semaglutide versus the frequently used duaglutide. While the study's primary focus looked at change in A1C, this also looked at the secondary endpoint of change in body weight. Without a doubt, the primary endpoint was met and showed favorable findings with semaglutide. So it's not on this slide, but the A1C change was around 1.8 with semaglutide versus 1.4 with duaglutide. Where I want to focus, though, is on this bolded portion of the slide where we can see that semaglutide over doubled the amount of weight loss that we saw at 40 weeks. So 6.5 kilograms versus 3 with the active duaglutide. Interestingly enough, we actually saw fairly similar rates of gastrointestinal side effects with both of our GLP-1s. The SUSTAIN-10 also looked at a comparison of liraglutide versus semaglutide, both at diabetes dosing. Again, the primary outcome was our change in hemoglobin A1C, but a secondary endpoint looked at our weight loss, again, a point of interest for the purpose of this presentation. Similar to our SUSTAIN-7, semaglutide outperformed liraglutide in terms of A1C lowering, not on the slide, but semaglutide was more close to 1.7 versus liraglutide was at 1. But again, we saw higher rates of weight loss with semaglutide versus liraglutide. Unfortunately, this did trend towards our higher rates of gastrointestinal side effects with semaglutide, as well as the discontinuation. So we're really starting to look at this plus minus and risk versus benefit. This final slide that I want to focus on before we move on to some of our patient case and emerging therapies looks at a final comparison of all of our GLP-1s, where really semaglutide has outperformed some of our other agents. These comparisons in the study looked at different doses of semaglutide, exenatide, duaglutide, liraglutide, and lixisenatide. Our blue bars at the right-hand portion of this screen really demonstrate the superior weight loss with semaglutide versus some of our other agents. We can see why this was first approved for diabetes, but then later for our weight loss. So how does this information apply to a patient case? So let's talk about, we've got a 64-year-old female who comes into clinic to discuss weight loss options. She's pleasant, engaged. Interestingly enough, social-wise, she works as administrative aide and billing specialist. And this is important because she really states that her desk job limits her activity and movement. And then she works long hours, so she says once she's at home, she's really fatigued. Overall, she knows frustration because she feels like she's tried everything. This is probably aligning with many of the patients that we've talked about in terms of weight loss. She feels like she's tried things, maybe they've been successful, but then cannot stick to anything and then regains back the weight. One of the key questions that we always ask as part of our weight management clinic is not only what's your food plan currently, but what is your diet that you've tried before? And we use the term diet very sparingly because of the negative connotations, but this helps to give us insight into what brand names have you tried or what have you followed. She's never seen a dietitian, but she would be open to it. She feels very overwhelmed because of the multiple findings that she has on the internet. She's tried Google searching everything. Objective findings include an elevated BMI at 42, slightly elevated blood pressure, normal heart rate, CMP and TSH are within normal limits. We frequently check TSH levels just to make sure somebody doesn't have hypothyroidism, and a slightly elevated A1C at 8.2. Past medical history includes hypertension, sleep apnea, diabetes with neuropathy, osteoarthritis, as well as depression. And she's taking amitriptyline, pregabalin for the neuropathy, metformin for diabetes, hydrochlorothiazide for her hypertension, bupropion, citalopram for her depression, and then aspirin for primary prevention. She does note that she's got private insurance and would be willing to pay for a prescription agent, but cost may be a barrier for this. Now, this is key. We are going to look at a patient video here soon, but what are some of the critical considerations is asking some of those motivational interview questions. So one of the key things I talk about as a pharmacist involved with weight management is what have you tried before, specifically any herbal supplements, prescription agents, or over the counter to help with weight loss? Based upon this question, she answered that she noted something in her 20s but doesn't remember the name. She did feel like it significantly upped her energy, probably something more in lines with fen-phen if we think about the generational. No prescription medications at all were prescribed as a result of her efforts to lose weight. We do inquire about, something should have stuck out if we think about Elizabeth's presentation in terms of medications that can assist with weight loss. And bupropion is one of them. If we think about Contrave, we've got that bupropion naltrexone component. And she did endorse taking it for years. She doesn't remember if she lost any weight when she first started therapy. Frequently, I'll ask, what are your thoughts on medication A, or can that be an option? And B, what do you think the medications would do? And she does note that she does not want anything that causes drowsiness or fatigue, that would be off the board just because of her work schedule, but she's completely agreeable to any injections. If we are thinking about that GLP route, if we think of our first couple of slides, we do need to screen and ask active questions about any pancreatitis history, as well as family and self-history about thyroid cancer. And then the absolute bottom line, we talked about with the trials, you saw that not only did we start the medications in those trials, but then there was also some sort of lifestyle component, both with food and activity. And that's frequently one of the first conversation pieces that I have, is that the medications aren't miracles. So they work in combination with dietary and lifestyle changes to make sure that we level up our weight loss journey. So let's take a look at our visit when the patient is agreeable to a GLP-1 and we start therapy.
Janet, that's all great information. Thank you so much for sharing it thus far. That helps really hone in on what medicine may be working best for you. There's one that really sticks out for me that would help both with your diabetes as well as your weight loss, and that's called semaglutide or Wegovy. I know you don't love the injections, but the nice part about this is it's once weekly. Most of the people that I have on this either take it on Sunday or Monday, just from the standpoint of helping to remember to take it each week. I'm going to start a relatively low dose and then increase it monthly, as that helps with weight loss and then tolerability. And overall, the literature has been pretty positive with showing weight loss.
That sounds like a good option. I'm just a little bit concerned about, with all of my other meds that I'm taking, that there might be some side effects.
Yeah, that's a great concern to bring up. Overall, it seems fairly well tolerated. Usually the most common side effect that I see with this is more stomach gut related nausea, bloating, or may have a little bit of vomiting. This is really based on how the medicine works, because it slows down both your gut and your stomach, which helps you actually to feel fuller quicker as well as longer. This can also sometimes help with avoiding overeating. The good news is that if it does happen, it usually goes away within the first 1 to 2 doses because your body gets used to it. What are your thoughts on what I've talked about so far?
It sounds pretty manageable. I guess I would just have to know how to do it.
Yeah, no, that's a great question. So it comes unfortunately, I don't have a demo in office, but I can send in a comment to your pharmacy to teach you how to do it. Each pen is a one-time use. So on one end, you remove the cap. On the other end, there's a button, and you're going to push the button to inject it, and you'll hear 2 clicks for the administration. The injection itself goes into your stomach. So I say put the end that you remove the cap on about 3 or 4 finger widths away from your belly button, and then make sure you rotate sites on your stomach to avoid any pain at the site or any tenderness from week to week.
Okay.
The last thing I kind of want to loop back to real quick, something that you said about the nausea. The other thing that can help with both preventing the nausea as well as making sure we're helping with weight loss is when you do eat, I say usually look at your plate, eat about half of it, and then determine if you're still hungry. This medicine is so effective in decreasing your appetite, and it can actually be where you feel fuller quicker. So that can help with both of those avenues. What questions do you have so far about anything that we've talked about?
I don't have any right now, but I'd like to, keep talking about it and getting more information.
Absolutely. I think following up in 4 weeks to make sure that we're tolerating the medicine and seeing if we can increase it is a great option. But then you obviously always have access to me to send me a message via your electronic medical record as well.
Oh, great.
I do want to follow up just to make sure that I've explained everything. Can you kind of summarize some of the key points that you've taken away from this discussion?
Sure. The medicine that you'd want to put me on, you said, people have found some success with it. So, I'll take it once a week. You thought maybe the beginning of the week would be good, and to help control my diabetes and weight loss. And to do that, once I take it, I should eat maybe half of my plate of food and then pause and just kind of assess. And if I'm full, then I should stop eating, because if I overeat, then it can cause some of those side effects of nausea and bloating, which I would definitely want to avoid.
Perfect. So I think you highlighted it well. We'll definitely start that medicine. I do also want to talk about some of our food and activity changes we can, because the medicine's good. The two together are even going to be better.
Oh, sounds wonderful. Thanks.
Awesome.
Awesome. So Jana was a great example of a successful counseling session. We really focused on A, the administration, B, the potential side effects, mainly the GI related, and then strategies to mitigate. So mainly focused on that mindfulness and eating and trying to do the half plate method. The next portion that we're going to go on to is some of our emerging therapies. But the first one that we'll talk about is a new molecule that's really being, or hormone that's being studied, primarily related or a sister product to our GLP-1. So our glucose-dependent insulinotropic polypeptide, or GIP, is a new target for diabetes therapy. In addition to GLP-1, it's an integrin model that focuses in the brain, gut, and adipose tissue, and again, mirrors some of our activities for GLP. So tirzepatide is currently being reviewed by the FDA for approval for diabetes and acts as a dual GIP-GLP receptor agonist. Similar to our GLP agents, this is an injection with a dose titration schedule. Trials have mainly been focused on patients with diabetes, with one example being the SURPASS-2 trial evaluating 3 different doses of tirzepatide versus semaglutide. While the primary focus was change in A1C at 40 weeks, we did have a secondary endpoint looking at weight loss. Overall, tirzepatide outperforms semaglutide for A1C lowering, but where I really want to again focus is on our weight loss options. On the left-hand side part of the screen, we can see something consistent with what we saw in the SUSTAIN cases, where semaglutide helped with an overall about 6 kilogram weight loss over this period of time. What's exciting is that tirzepatide really almost doubled those results with the max dose consistent with almost a doubling at around 11 kilograms. On the right-hand side, we see significantly higher percentage of patients who lost both 5, 10, and 15% of weight loss. And again, we keep in mind that semaglutide was one of the first when we remember our prior trial that looked at about 15%. This is really a fraction of what that prior study duration was. So I'd be excited to see what this percentage of 36 would look like if we did the full 68 weeks like the other trial. Overall, tirzepatide has not been solely studied for weight loss as a primary outcome, and the FDA approval is only for diabetes at this point, but the secondary outcomes for weight loss are really promising. I'm hopeful that we'll see more of this agent in the future for weight loss. Unfortunately, similar with our GLP-1s, GI side effects were the most prominent. However, event rates for both tirzepatide and semaglutide are really a lot lower than what we saw in the prior trials. If we remember ranges between 10 and 20%, these are fairly low compared to those other trials. And then where I want to end this module is with a holistic approach, looking at all of the medications Elizabeth touched on in the first session. A meta-analysis was just published comparing all of these medicines for weight loss. On the left portion of the graph, the darker the green means the more weight loss we saw in trials, where our high performers include phentermine, topiramate, bupropion, naltrexone, and our GLP-1s. But then we're balancing it with the right-hand side of the graph, where the darker the red, the more side effects, with our highest agents for side effect profiles being GLP-1s and bupropion, naltrexone. So we're almost doing a risk-benefit evaluation. Some key takeaways from Module 3 would be liraglutide and semaglutide are currently our only GLP-1 agents for weight loss in the absence of diabetes, with further trials coming out for these. GLP-1s as a class, though, can be used for diabetes and for weight loss. These higher doses of liraglutide and semaglutide, liraglutide 2.4 and 3 milligrams, and semaglutide 1.7 and 2.4 are approved for weight loss compared to some of our lower doses for diabetes. Some of the key things if we are prescribing these are to help with avoidance of adverse events with the mindfulness and eating, our administration, and then also worrying about or warning the patient about some of these potential side effects. And then more on the rise about tirzepatide, which is a dual GIP-GLP-1 agonist, which is currently in clinical trials and being evaluated for diabetes by the FDA. More to come on the weight loss. With our final moments, let's take a glance into our final module with optimizing use of obesity treatments and overcoming barriers to care. Through this module, we'll talk about barriers to care and strategies to help overcome those. So let's come back to our patient case. If we remember, Janet had a lot going on. Really what I want to highlight is some of these barriers so that we can set some SMART goals moving forward. We see that she does have some social situations, mainly related to her job, that she's frustrated. Her desk job really limits activity. She has very little energy. As a baseline, she feels like she's tried multiple strategies with none of them being stuck or successful for long periods of time. It is important to look at both medications as well as past medical history. I always argue that chronic pain as well as depression can sometimes limit our food and activity goals, as well as amitriptyline and even arguably pregabalin may be a barrier for weight loss, keeping weight on. Additionally, cost is something that we definitely need to evaluate in terms of medication options. So let's also review, we talked a little bit about, in Janet's case, comorbidities that I would be looking at as barriers for weight loss. Frequently, many of these patients are also struggling with other comorbidities and other complications. Some of these include chronic pain syndrome, which again, we need to be strategic in what we're talking about with activity level, depression and anxiety, especially if it's not currently controlled, menopause, hypothyroidism, as well as testosterone can all be barriers and things that we need to consider. This slide is a reminder from Elizabeth's presentation where we look at different medications, and this is a great opportunity for pharmacists to be involved to make sure that we are optimizing medications in use. So for example, this patient was on amitriptyline, which is a really good highlighting agent for that can be a barrier. Frequently, I'm also looking at, so her metformin for diabetes is not something that would keep weight on. I commonly see patients come in on sulfonylureas and insulin, which can be significant barriers. I just saw somebody actually today who last appointment, we took off her glipizide and she feels she lost about 6 pounds within a month and she feels like she's made some dietary modifications, but that really helped with decreasing her appetite alone. One of the key things that I talk about, because I do feel like frequently individuals that had barriers in the past or have not had success with weight loss, is that they're trying to do a complete overhaul of their lifestyle, and that's just not feasible. A lot of the things we're talking about is how do we incorporate this to not be a diet, not to be a crash course of anything, but how do we incorporate this to be a healthy modification for the rest of your life? So let's talk about some of the barriers that I hear frequently in my practice and some of the strategies, how we overcome these. So situational barriers, Janet had a great example of this in terms of her work. She was exhausted after work. Frequently, I hear about people as a social situation. They like to go out with family and friends, and that can be difficult. Work tends to be a barrier because they don't have time to pack a lunch in the morning, or acute pain limits activity. Some of the strategies that we will talk about, again, is minimal. Can we pre-plan? So can we check the menu wherever you go out to eat beforehand to pick lower calorie options or ones that are higher in protein? Can we do an activity for 15 minutes on lunch? Again, this is not where we need to go. If you go from no activity, we don't need to go immediately into 60 minutes every single day. So how can we just get up and walk rather than sitting? What about meal prepping? Is that an opportunity that on Sundays we can all do that as a family? And then if acute pain, we frequently refer to physical therapy as well as water therapy to help with activity. We got some great questions on intermittent fasting, and this can frequently fall in line with helping to meal plan, or if you have an issue with maybe we don't get breakfast in consistently every day. The studies are somewhat limited with intermittent fasting, but the studies so far are fairly positive, both with weight loss as well as with glucose management. So this is an option that you can always talk about with patients. So intermittent fasting being we have so much time where we aren't eating anything, and then usually about 8 hours where you have a time frame to eat. Some other opportunities, so stress and depression, so feeling down because of recent weight gain, no time to focus on me, frustrated with everything that's failed. Frequently, as part of our visits, we're screening for depression and anxiety and appropriately treating with hopefully one of our lower risk medications. We frequently talk about journaling, so that helps to exhibit some of your emotional thoughts in regards to weight management. And then setting realistic goals. And social pressure coming along, so family does not support diet, friends want me to go out, as well as picky eaters. For the purpose of time, we'll include some of these here, but we can talk about finding a point person and support, expectations, as well as joint appointments with family. Food cravings also tend to be a large barrier in terms of successfully incorporating dietary modifications, with probably one of the biggest things that I talk about is hunger and cheat foods. We got some great questions about this, primarily with increasing water intake, which is a great strategy, as well as increasing protein. We did get a question in terms of keto diet, and I do have to say, both Elizabeth and I discussed this, we do not support fully keto diets. I do have to say, though, frequently, if you're hungry, increasing protein is a great option, as well as making sure we get adequate water intake. We do not recommend a full keto diet, though, because that usually tends not to be successful, and patients have increased cheating as a result. And then cost tends to be a barrier as well. Frequently, we will establish with gyms to see if we can do reduced rates, such as the YMCA has an income-based program, free local events, outdoor activities. The key thing is to make it so that it's workable within somebody's lifestyle. The key thing that I want us to take out of all of this, we talked about multiple barriers, and due to time constraints, couldn't get into many of them. But really what we try to get out of our appointments within the weight management clinic is making sure that we take away 2 to 3 SMART goals. So specific, measurable, achievable results in a timely fashion. So an example of this where I've been frequently talking about is water. If we are dehydrated, that can frequently be seen as hunger. So I will not eat or drink anything but water after 7:30 p.m. for the next 4 weeks. Another perfect one would be if we don't have any water at all, making sure that we have 4 cups of water each day, and I will measure that and report back within the next 4 weeks. And I'm going to continue on. We've kind of highlighted some of these key discussions that we had with Janet. Again, some of the key takeaways is if we're prescribing medications, talking about our mitigation strategies, as well as making sure that we set the clear expectation that if we're starting medications, we're also talking about lifestyle interventions. So coming back with some of those SMART goals that we have.
So Janet, I think we have a great activity plan moving forward. I do want to switch the focus a little bit and talk more about food. Do you currently track your intake?
My food intake? No, not really, but I know I'm just eating tons, lots of snacks. So
do you feel like that would be manageable to write down your goals via like paper or even an app on your phone?
Oh gosh, it probably would be good, but my work day is really stressful.
I completely understand. Let's maybe back it up a little bit and talk a little bit. What do your meals and snacks look like right now?
Oh gosh. It's usually during the day. I'm just running around. I get something in the morning. I don't have time really to think about making a healthy packed lunch. And I get to work and lunch is pretty much a toss up, either having something delivered or go out and grab something. And then I work late till 6 or 7. So by 4 o'clock, I'm hungry again. So I'll have snack chips or, something that's not good. Then I get home and my husband has usually made dinner, and whatever he's made, which, usually isn't super healthy, finish that up. And then later in the evening, we're watching TV and, grabbing another snack while we're, sitting and watching TV.
Okay. So we definitely, it sounds like, need to find a plan that works around your job as well as some of the time constraints that we have. The positive is that the medicine that we talked about earlier will definitely help cut down on your appetite and increase that time between meals. What are your thoughts so far on that?
I think I could probably try that. Yeah.
The key thing that I'm hearing, though, is if you're still hungry, that may mean that we're not getting enough protein. Have you ever tried a protein shake or snack?
No, I haven't tried that. But, if you think it'd work, I might try it.
Yeah, I usually think that this is a great option, especially if we don't have time to meal prep and we need to keep you fuller for a longer period of time. Frequently, I have people buy them in bulk and then just leave them at work. What are your thoughts?
Sounds like something I, could probably do.
Okay. The other thing that I'm kind of hearing that I do want to bring up is that sometimes I find that it's helpful to not eat in front of screens, mainly the TV. A lot of the times this will lead to more mindless overeating, especially if we're not hungry. What are your thoughts on what I say about that?
That's probably true.
Okay. So we talked about some great content in terms of food. What did you take away as maybe 2 food-related goals that we could do before next appointment?
Well, trying the protein shakes, replacing a snack or even a meal. Also, just trying to cut out eating while we're, sitting in front of a screen.
Okay. I definitely think that those are great goals. I am going to specifically ask about those at our 4-week follow-up, but I'm even going to message you beforehand via our electronic medical record to see how the goals are going within the next 2 weeks.
Okay. That sounds great.
Fantastic.
Now, we focused heavily on GLP-1s. I want to take a moment to talk about some of our adverse event management for some of our other ones. So if we have a stimulant component, something like our short-acting medications or phentermine or bupropion, a lot of these can be associated with insomnia. So taking them in the morning can help mitigate that strategy. Topiramate can cause some fatigue, which making sure to take it at night can also be helpful. It's also important that topiramate can cause kidney stones, so making sure that we increase our hydration. And then we talked about liraglutide and semaglutide in terms of some of our mindfulness in eating. For medication access, we got tons of great questions about this. I spoke about the GLP-1s, that you do have the coupons available. For both phentermine and as well, phentermine, topiramate, naltrexone, bupropion, the combination brand agents, there are coupons available. This can still somewhat limit as both of them are around $115, $120, but so we may break them into the individual components to help with the cost management. Then we got specific questions on orlistat and the cost. This does tend to be, the prescription agent tends to be insurance specific. Over-the-counter tests tend to be a little bit more affordable, where I've seen people get that. The brand name, though, for prescription is very insurance specific, with most private insurances being a hit or a miss whether or not they cover it. So this is a great opportunity. I hope that you feel invigorated after listening to all 4 modules, that pharmacists are in a great position to help encourage patients to minimize medications that can contribute to weight gain, as well as overcoming barriers that can either cause weight gain or barriers with weight loss. Lifestyle interventions are a critical component, not only the medication to ensure success, and pharmacists are in a great position to make sure that we set smart goals that we can follow up in a timely manner with very minimal changes, so not complete lifestyle overhauls. When we are prescribing medications, we do need to talk about those adverse events and making sure that we talk about the mitigation strategies like we talked about before. Stimulants take in the morning, Topamax we take at night, GLP-1s, the mindfulness in eating. And pharmacists are in a great position to talk about cost reduction strategies, breaking up the medicines, using coupon cards, as well as seeing insurance benefits as to what's covered. So thank you guys so much for being on this journey for me. We came right up to time, so we really covered quite a bit over the 2 sessions. We see that obesity is increasing in prevalence, which is why we need to have the conversation today. There's multiple components about it: food, activity, medicines, as well as the other socioeconomic, as well as comorbidity issues to keep in play. Our guidelines indicate that a goal of 5 to 10% weight loss over 6 months is great with helping to prevent against many healthcare complications. And we can focus both on those dietary activity as well as medications to be successful in losing that weight. Currently, weight loss is a great discussion because pharmacists have a role, but there really are limited medication options available. Hopefully, we're seeing newer therapies on the horizon. And then at each appointment, the healthcare team needs to be vigilant in talking about these barriers as well as potential side effects and ongoing medication use.
Thank you very much, Dr. Adelman and Dr. Pogge, and thank you to the listeners for joining us. As a reminder, to view the full program and join the discussion, please click on the link in the show notes. As always, thank you for listening.